Hello, everybody. This is Josh Hagedorn from TBD Solutions, and we've been asked by Lakeshore Regional Partners to do a series of webinars to supplement your implementation of the data analytics platform for population health management, and to give people sort of an overview of the state of the art in a number of different areas, as well as to make sure that people are apprised of relevant national initiatives that are relevant to the services they are providing. So what we'll be doing today is sort of a whirlwind tour of measurement, the framework, the standards, the reasons why to measure, and some of the ways how to measure, specifically for behavioral health care. A lot of this information is compiled out there for physical health care, but not as many resources exist for measures that are relevant for behavioral health care. So we're going to be spending some time looking at that. One word of warning as we go through this: the information that we're going to be presenting today continues to change. New initiatives come up, there's new payment programs come up, etc. And a lot of this information, especially in terms of which measures are included in which initiatives, or which initiatives exist even, since a lot of them are pilot programs, a lot of this stuff continues to change. What is starting to congeal a little bit is a core set of quality measures that are related to behavioral health, and then also a lot of the comorbid conditions that are prevalent among people who have behavioral health conditions. So while that caveat holds true, a lot of the things here should be generalizable and useful even through the coming years. So what we'll be doing today is really two basic things. We want you to know why to bother measuring, and we want you to know how measurements are constructed, so that even though you may not be designing them yourselves, you'll be able to understand the basic pieces of measurements that are reported and used to measure quality and clinical processes for the services that you provide. So we'll be doing this in really 4 basic parts. We only have an hour together today. We schedule these webinars during lunchtime, hoping that you could, while you are eating a nutritional lunch, you can tune in and sort of get an update on where things are at in the industry. So our outline is only 4 parts today. We're going to be looking at the business case for quality measurement. For those of you who are CEOs, this is especially for you. For those of you who are not, this is for you to bring back to your CEOs, and as a way to make sure that the larger case for going into this work is well understood. Second, we're going to look at context. Some of this is what drives the business case, but we're going to look at a lot of the national and even state initiatives that require the use of quality measurement. We're then going to talk about framework, about the types and domains of measurement, specifically for the population that you guys are serving. And finally, we're going to take a tour of existing measures, including sort of digging into the pieces and parts of a measure. So let's get going. So our first section is the business case. A lot of what I'm saying will be in very broad strokes. And there are lots of different variations on types of value-based purchasing. Value-based purchasing is really a topic in its own right and has lots of different applications and models that are being rolled out in multiple pilot programs. But the essence of what this means is that lower performance means lower pay. Now, I could have said higher performance equals higher pay, but people tend to be less incentivized by additions and much more incentivized by subtractions. So there we have it. A few things that are worth saying. While a lot of this terminology has been bandied about and has almost become sort of a buzzword over the past several years, one thing, it's worth realizing that there are a number of very specific applications of these models that are currently impacting providers. And it's not, so even if you are not currently part of a value-based purchasing arrangement, the question is not so much if you are going to be involved in one, but when. And there are specific steps that you can take to prepare for such an arrangement. If we look at just some of the news reports that are available from the past year, there are instances where Medicare is cutting hospital payments based on reported safety errors. There are instances, there's the plan that Medicare has for moving 30% of its payments to being value-based by the end of 2016. So that is 1 year. And then 50% by the end of 2018. There are increasingly heightened data collection and reporting requirements. So this is not just Medicare, but under Medicaid initiatives. So DSRIP is the acronym for Delivery System Reform Incentive Payments. And those are initiatives that are going on within the Section 1115 integrated waivers that a lot of states are moving to for Medicaid, and of which Healthy Michigan is an example. There is also a growth in the number of Medicaid ACOs nationally, in addition to Medicare ACOs. Which leads us to our next slide, which shouldn't need saying, and yet a lot of times ACOs and a lot of these payment system reform models are left out of the discussions that we at least hear related to strategy for mental health. And so here are two very recently published, I think as of March, 2015. This is looking at the number of ACOs by referral region across the entire country, as well as the percentage of the lives in that area that are covered by ACOs. So these payment systems are real. They exist. There are over 165 ACOs that are being certified by CMS and which have been announced for both Medicare and now for Medicaid shared savings plans as well. And yet, 37% of the ACOs lack relationships with behavioral health providers, and some of this, there are multiple reasons for this. Some of it is oversight and planning, and some of it is difficulty sort of finding interested parties. But a recent survey out by the Commonwealth Fund found that this is a really key area that current ACOs are missing out on, and therefore a key opportunity for any behavioral health organization or provider. So one of the other drivers of business case is public accountability, right? So where we talked about value-based purchasing, there our incentive is we don't want to get paid less by funders for the things that we do. Public accountability is another incentive because we may actually have fewer patients choose the services that we provide. Again, a very specific set of examples are available and listed below. More and more data is available, and really to anybody who has access to the internet, anyone can go on and look at the ACO outcomes The links are all available here and will be available to you afterward in case you're trying to note these things. Federal reports, the president issued a requirement several years back that said that all federal data must be machine readable, which means that it needs to be able to be used by computers, and therefore it can be fed into any sort of application that somebody might want to build, right? So you can get that data fed into an application for your phone that helps you to compare the providers of a specific type of services in an area. And that information is more and more going to be available to customers as a way to help them to make informed decisions about the services that they receive. The bottom instance here is a small local instance where there is data available currently on AFC homes that anyone can look at. Another example here, so I pulled this up for an area near the neighborhood that I live in. And I thought, okay, so if I wanted to compare nursing homes in this area, I can go to Nursing Home Compare, and I can look at the performance of multiple providers in my geographic area. So let's imagine if the programs that you are currently providing were put up on a site like this. What implications would that have for the way that you did marketing, for the way that you did quality improvement, for the amount of weight that you put on a specific measure versus another? How much attention would you pay to your performance if it was reported to prospective customers on the web in an easily accessible format? What if you had a star rating that was based on your overall performance? So here we have 3 separate providers, each one with an above average, below average, and much below average rating. Which of these would you choose if you were placing a loved one into a nursing home? So that, in brief, and very brief, is the business context sort of for starting to invest more heavily and pay more attention to clinical and quality measurement. Next, we're going to talk about another set of incentives, but these are really more compliance-based incentives. And this is looking ahead at what are likely to be the compliance requirements of the near future. So what we have here, and this violates like all sorts of rules about PowerPoint slides and the number of things you put on them, and yet there are lots of initiatives. So don't feel like you need to read through them. These are just a sampling of 27 of CMS's initiatives which involve a heavy dose of quality measurement. And the ones that are relevant specifically for behavioral health are noted in orange. And we'll go into detail on a few of these in the next several slides and look at the measures that are related to those and sort of what the context is for each of those relevant initiatives. We won't be able to get into each and every one of these, so if you have questions, feel free to send an email over afterwards, call, or just look them up yourself on the CMS website. So the first one that we're going to look over briefly is a reporting initiative called the Physician Quality Reporting System. So this is an initiative under Medicare, and it's an initiative that has caught a lot of behavioral health providers by surprise this year, despite the fact that it was announced pretty widely throughout the initial years of its implementation. So the way that this initiative was set up is that people who began reporting a set of measures they had to choose 9 measures from a very long list of possible measures and start to report those back in 2013. And for people who started reporting back then, for physicians who provided Medicare services and who began reporting on these measures in 2013, they got an incentive payment. Now, if they did not report on those measures in 2013, they didn't get an incentive payment, but an adjustment payment is what that's called. And that adjustment payment is hitting in the current year. So in 2015, there's actually a negative 1.5% adjustment for people who failed to report in 2013. So there were carrots offered at the beginning of this program, but now really we're in the part of the program that just involves sticks. So now it's a compliance requirement. And our best guess, is that a number of the other initiatives that we're going to be reviewing in subsequent slides will have something of the same effect. So while these are not requirements today, anticipating that they will be requirements down the road would be in people's best interest. And PQRS is really sort of a warning of what could happen if providers and mental health centers don't pay attention to these upcoming requirements. Next, a topic that many people have likely heard of are the health homes that are established under Section 2703 of the Affordable Care Act. And this section allows states to provide health homes specifically for enrollees with chronic conditions. And there's a set of 8 core quality measures as well as 3 utilization measures. And we'll talk about the importance of those different types of measures in the next section. So just to note, though, that these are measures that people were not really, at least consistently measuring prior to this effort. However, these measures are going to be used in long-term evaluation of this model to determine its impact on people who receive health home services versus those who do not receive health home services. Another example is the inpatient psychiatric measures with the lovable acronym of HBIPs. And so this is something that the Joint Commission actually developed this set of measures years back and have begun to require anyone who is certified by the Joint Commission to report this set of measures for its inpatient psychiatric hospitals. And then those measures, people's performance, is actually made available on the Quality Check website, which is linked here, and where we have another screenshot specifically for hospitals, again, in my local neck of the woods. And here we're looking at 2 separate hospitals, and you can see how each of them performs on the measures that are in this HBIPS measure set. Right, so for anybody who wants to contract with these hospitals, for anybody who wants to send a patient there, the performance data from previous years is available for anyone to look at and to compare hospitals by. And you can compare like a whole set of hospitals using this website. And finally, we wanted to spend a little bit of time on what is likely to drive a good deal of the compliance and advancement of standards in behavioral health quality measurement, which is the CCBHC, or Certified Community Behavioral Health Clinics, which were developed underneath the 2014 Excellence in Mental Health Act. Now, one of the key features of this proposal is that all CCBHCs include a common scope of services and also are evaluated by common quality metrics. When you're thinking about CCBHCs, it's kind of helpful to think about them as behavioral FQHCs, if you know anything of that model. And a lot of the goal here is to develop a core foundational set of standards for evidence-based treatment in community-based behavioral health. It may also actually start to merge with some of the requirements around reporting for the uniform data system that the FQHCs use in reporting, and make that data available alongside FQHC data in regions. One of the other things that the CCBHT proposal includes is it defines the payment system as a prospective payment system, which is being designed to incentivize value and not volume of services. So in concert with the payment system that will be implemented, these quality metrics will be a way of really developing a first prototype of value-based purchasing for behavioral health centers. So next, we are going to get a little bit closer to the guts of how these measures work, but let's start by setting up a framework to have this discussion in. There are lots of details and lots of sort of different pieces and parts that can be moved out, but having a broader sense of what quality means and a common language to discuss that is helpful as we start down this road. So first off, we're going to talk about the language that we use. In order to develop common measures, which is the goal of CCBHTs and really all of these national quality initiatives, in order to develop those common measures, we're going to need to have common definitions. So way back, I was going to say it seems like years ago, and it was, HHS defined a national quality strategy. And it also defined a specific framework of measurement to support that strategy. Now, behavioral health, specifically SAMHSA, has been developing a national behavioral health quality framework to align with these national standards in healthcare that were defined under the national quality strategy, and thereby moving from the sort of current state of affairs where we have, every state and then probably even more different standards for quality measurement in behavioral health to a single framework. So the links are here. I would suggest that you hop on and actually look at the details of the behavioral health quality framework and how those are connected to the national quality strategy, because this is really informing how all quality measures get prioritized, as well as how any of the CMS incentive payments or pilot projects get developed, is based on a proposal for how they can meet this value proposition. So how do we learn to speak this language? I mean, when we're learning to speak a language, usually we don't pick up a dictionary and start to speak the language, because the dictionary is gigantic. And there's plenty of dictionary to go around for these quality measures. But before we even start talking about that, we need to talk about something really basic, sort of the nouns, the verbs, the basic pieces and parts of what these quality measures are made of. And for that, it is helpful to reference a good friend, which all of you are probably familiar with, which is the triple aim. So the triple aim works really well, and a lot of people will sort of see it in slides, I think, and say, like, oh, yes, we've heard of the triple aim already. We know all about that. And that's what makes it so wonderful, is that it's a really good framework and it sticks in your mind. It's very hard to forget the triple aim once you've been exposed to it enough, which you have likely been exposed to enough. And that's not on accident. Like, that's a very targeted part of the communications that are consistently coming out of HHS, CMS, and then trickling all the way down to state government and local initiatives. So a good framework, which I would argue the triple aim is simple. So it needs to be something that you can remember without a sheet of paper in front of you. For instance, in the department store Nordstrom's, I don't know how many of you have gone to a Nordstrom's, but they have one rule for their staff. And their rule is exercise good judgment at all times. So it's very difficult to forget that rule. Rather than having a gigantic set of policies, procedures, etc., a simple rule can act as a way for individuals to make decisions on the fly that doesn't require referencing some handbook. So the triple aim is really useful as a framework because it is simple. It's easy to communicate with other people, and it can be defined and applied fairly consistently. It's also related to purchaser requirements, which really relates to all of the specific initiatives and the national quality strategy and behavioral health framework that we just referenced. On this slide, you will see the familiar triple aim triangle, but then also on the right, we've included a screenshot from a study that was, or a white paper that was put out by the Institute for Healthcare Improvement that looks at some specific proposals for measuring the triple aim. So not just adopting it as an overall framework, but how specifically do we go about measuring each part of the triple aim to gauge our performance in meeting those objectives. So here we have mapped the triple aim to a number of the other frameworks that we've talked about. So here we're looking at better health, better care, and lower per person cost, the three aims of the triple aim. And we're looking at those related to three separate national initiatives. And we wanted to do this primarily just to flesh out what types of things specifically fall into each aim of the triple aim. It's especially, with all of the potential quality measures that are out there, it's important to make sure that we're bringing each of the specific things that we encounter back to this broader framework. So here we see the BHCOE stands for Behavioral Health Center of Excellence, which is a program being run by the National Council for Behavioral Health Care. And you'll see like excellent outcomes is one particular tenet of the Center of Excellence, and that's aligned with behavioral health. Better care, so a lot of times better care in the triple aim has been defined as patient experience. Better care is really, if we're thinking in terms of measurement, better care is made up of patient-reported experience, which includes things like satisfaction surveys, experience of care surveys, like the CAPS survey for hospitals or ECHO for behavioral health plans. It also includes making sure that somebody gets the best care that they can receive. So did we follow clinical guidelines in providing care to a person? Did we do what we know to be evidence-based practices in treating a particular condition? All of those things fall inside of better care. And you can see how those map to the Center of Excellence, also to HHS's National Quality Strategy, which we just referenced, and to the SAMHSA National Behavioral Health Quality Framework, which is also referenced on the slide above. And then finally, lower per person costs. It's important to reference the per person here because it really is, it's not just spending less money overall. It's not about state budgets. It's about more efficient care for each person who you serve. So, like we said earlier, the triple aim is helpful as a framework, not only because it maps to all these other initiatives, but because it sticks in the mind easily. So as you're sitting down with other quality staff, with an executive team, with other people in your organization, at different levels, you can use the triple aim as a rule of thumb. And a heuristic is really a rule of thumb. So you can, at the health plan level, you may ask, is this population getting healthier? And let's ask that question by stratifying across multiple different types of populations. At the provider level, you're going to be asking the question based on, are the specific set of people who are entrusted to my care for this service or who are referred to me, are those subpopulations of people getting better? And then finally, at the practitioner level, is this patient who I see before me right now, are they improving? And how am I measuring that at each of those levels? There's going to be different ways of approaching that issue. In the better care category, at the health plan level, we may just be interested in a lot of the process measures that are being used in quality measurement today, which basically ask, are clinical protocols done for health conditions that are a really high priority for the population? At the provider level, some of those same tools and measures may be used, but specifically using them to benchmark against other providers, and then also just to make sure that they are actually impacting practice and that processes are being redesigned when measurement in those areas is not up to the average or up to sort of the expected level of performance. And finally, at the practitioner level, you can ask, am I providing the best services possible? So each person has a responsibility for each piece of the triple aim, in addition to the collective responsibilities shared by plans and providers. And then you can read the rest of the lower per person costs below. Again, questions at multiple levels of the system. So the triple aim is one helpful three-part way of looking at what are our aims in quality measurement. I thought we would choose another three-part system to look at not what the aims of measurement are, but what the objects of measurement are, right? So like what are the things that we are measuring? And we can group the things that we're measuring into structure, process, and outcome. And this is really based on Donna Bedian's framework that I'm sure many of you are familiar with. And the value of this framework is its simplicity. So there are three basic areas of this. And again, this is sort of a crash course for anyone who's interested in this broad topic of measurement framework. There's a lot more digging in and learning that you can do about each of these areas. So structure, the basic definition that we can use for structure is just the context in which care is delivered. Right, so the structure is, what do we have in place to perform a process? So we might want to know, like, how many full-time equivalents of psychologists do we have at a particular clinic? Right, so that's a measure of structure. It tells us the human resources, the technological resources, the processes, procedures that we have in place in order to provide care. Process measures talk about the actions performed for care, right? So for these psychologist FTEs that we talked about as part of a structural measure, the process measure talks a little bit about, well, what are those psychologists doing? Are they following a set of defined processes that the organization has defined, or the federal government has defined as being important processes to impact a high priority condition? So here, for instance, for depression, there are several measures that look at pre and post scoring on the PHQ-9 assessment, which is an assessment of depressive symptoms. So a process measure would be, did this psychologist complete a PHQ-9 assessment? And then finally, the last part of our triad here from Donovan is outcome. And this isn't looking at the process. It's not looking at what the provider does. It's not looking at whether they're following guidelines. It's looking at the effect of the work that they do on patients. So in this case, where we're trying to follow the same example all the way through, in this case we'd be saying, all right, based on those PHQ-9 scores that the psychologist completed, or that the psychologist entered into the record, do we see remission in depressive symptoms within 12 months from the beginning of therapy? Right, so that would be an example of an outcome measurement. So those two things, the triple aim and the Donovan framework for structure, process, and outcome, are two things to keep in mind as we now start making our descent into details. Here we're going to look at the structure and content of a couple of real-life existing measures, and we're also going to just be doing a sort of cursory overview of some of the most commonly used measures that are related to behavioral health. So let's talk about population health management, because it seems like no presentation can go by without hearing the words population health management. It's probably part of almost every single slide deck that you've seen in the past year. For our purposes today, we're going to adopt the overly simplified approach of just defining a population as a denominator. So for any of these measures that we're looking at, for really any measure, there has to be a denominator. And you all remember from grade school, a percentage is made up of a numerator or a denominator. So really, we're going to be looking at measures that take the form of percentage, which is really the majority of measures being used in public reporting today. So the population that's being addressed by a measure is akin to the denominator of the measure. So here we can see, so here we've defined two separate populations, but we can also look at the same set of measures across those two populations. So in the first instance on the left, we have adults who are 18 years and older with severe mental illness. And then we can look at, for that particular population, did they meet any of these other conditions, right? So how many of the people in that population had a PCP visit, and how many did not? How many were hospitalized? How many were not, etc. And all of this also, I mean, there's a lot more definition that needs to go into this, but this is the basis of how measurements relate to populations. And it's helpful, so when you hear anybody talking about population health management, when you hear people using some of this terminology, a helpful set of next questions is, well, what is the exact population of focus that we're looking at right now? So how have we defined that population? Like, have we defined a group of high utilizers? What are the conditions that we're using to define those high utilizers? So what is the number of services, for instance, for what type of services, which we would consider placing somebody in a high utilizer group? So the next thing that's worth going into is that this all requires different levels of specificity. So we talked about populations before. Populations at a state level have, at least in Michigan, traditionally been defined as MI, DD, and then children, and then also grouped into adults and children. So that's a really broad definition. depending on the audience that you're talking to, there's going to be different levels of specificity that, that you'll be using. So for instance, if you're driving on a highway, you might see, for instance, like, that your local hospital system ranked in the top 15th percentile of Truven Health Analytics hospital rankings, right? So that set of health rankings is done based on a very large collection of hospital quality measures. And really, so at the level of the public there, they're just saying we ranked in the top 15th percentile across all of these measures. And that's the top 15th percentile across the entire nation, right? So that's a very high level of reporting. So here we have, sort of tongue-in-cheek, a mix and match question. And I think the answer, I'm sure that you will all get 100% on this because I made it up as a joke. But really, it speaks to the different levels at which we need to engage some of these topics depending on the audience that we're talking to. So letter C here corresponds to a board member. And a board member may not need to know all of the specific details that go into the quality measurement. But the board member is going to want to know, are people getting better as a result of the work that this organization is doing? A level down with a little bit greater attention to detail here is the quality specialist. And the words that are here are actually the exact title of a quality measure that's endorsed by the National Quality Forum, and it's basically the one that we discussed earlier, which is remission of depressive symptoms that are based on a PHQ-9 score during a period of 12 months. Right, so this is probably the level of detail that a quality specialist would be engaging at. And then all the way to the left, we have the high level of specification for an electronic measure. So this is actually not even the computer code. This is just a high-level summary of the computer code that goes to constructing an electronic clinical quality measure. And I wanted people to be aware of these because the level of detail that goes into a lot of the shorthand remarks and advertisements and statements that people make is really based on an incredible level of detail, and this is going to continue to compound. One of the major issues that I think should be part of each provider and organization's strategy is really like, what is your plan for simplifying and creating a framework for all of this complexity? Because there's so much variation, there's so many different measures that are going to be available, and trying to build and pursue all of them as they're sort of falling from the sky is not going to be a really helpful approach. So taking a specific and strategic look at which measures are relevant to your population, are likely to be part of current and future compliance requirements, and are possible to build using the existing data that you have access to. Being able to walk through that process is a crucial step in managing your organization's sanity while preparing for the future. So we'll get into now the anatomy of a measure. And this looks so much simpler. So what this really is this is a high-level outline of that very complicated thing that you just saw on the left-hand side, where the electronic clinical quality measure is defined. So these are sort of the headings of the different pieces of those quality measures, and I wanted to walk through them because really every single measure that you will encounter, which is a national standard, will be made up of these pieces and parts. And we'll walk through and try to give some examples, and then I think even hop out and look at some real examples of how these things are built, or at least a couple of them, to give you a sense of how this looks for the actual measurements that you may be required to report on relatively soon. So the first main section is the population criteria. So this is where we define the population. And it's made up of a few different parts. First is just the initial patient population. And this is really the fundamental place where we say, all right, if there's a question that we want to ask, who exactly is the target audience, or who's the target population that we're trying to look at when we ask this question? So that's a really critical question to ask anytime that you're doing an analysis, and also anytime you're trying to understand one of these measurements and what exactly it's saying. So the initial population might be, for a behavioral health relevant example, we could say the initial patient population is adults with major depressive disorder. Then the denominator is usually, so if you actually look at these measures, a lot of times the denominator will just say the denominator is the same thing as the initial patient population. Another approach that you could take is you could say, all right, the denominator is the initial patient population, but the portion of that initial patient population who have received a specific type of service, right? So for these adults with major depressive disorder that we just referenced, we're going to say that the denominator is the portion of that initial patient population who have received outpatient therapy within the past 12 months, right? So that's a denominator. It's not exactly the same as the initial patient population, but it's a subset of those individuals. We also may want to exclude people from the population that we're defining. So let's say that we don't think it really, makes sense to count patients who had less than 3 or, less than 2 outpatient visits with those providers because it doesn't give enough time for the treatment to actually take effect, right? So based on some sort of standard of evidence and the strength of evidence around minimal amount of service that needs to be provided in order for a practice to be likely to have any effect, we might then have a denominator exclusion that tells us, all right, we're only going to include people who meet this standard. And then finally, the numerator. So for this patient population, and all the ways that we've filtered it with exclusions or by saying who goes in the denominator, the numerator is really the crux of our question, which is for this set of people, what happened? And like we saw a couple of slides back, there are multiple questions that we can ask about any given population, right? So how many of people in this population had this sort of a screen? How many people in this population had improved functioning based on a score on a standardized measure, et cetera? So those types of filters would then go into the numerator of the measure. So all of these things, so that really makes up the logic of the population criteria portion of a measure. All of those things, however, so when I said major depressive disorder, while that's a language that I'm pretty comfortable speaking as a human being, as somebody who's working in this industry, and when I'm talking to clinicians, this makes sense. It doesn't make sense to computers because computers are dumb. So the way that we make some of these broader sets of terminology make sense to a computer is through section 2 here, which is the data criteria. And this is where we define specific value sets. So if we say major depressive disorder, we'll want to define a value set, which is a subset of ICD-9 codes, for instance. And we'll say that those are the codes that mean major depressive disorder. So rather than defining every single one of those inside of the measure itself, we sort of use a broader term, and then we define the pieces and parts of what goes into that term, right? So outpatient therapy means, in terms of the data criteria, means a subset of CPT HCPCS codes, which we are going to call outpatient therapy. The next section is reporting stratification, right? So, and this doesn't apply for all measures, but there are certain measures where you'll want to report multiple rates. So for instance, if you were looking at the percentage of patients who had a case manager follow up post-hospitalization. So after they got out of the psych hospital, did a case manager follow up with them? And let's say that you wanted to have that measure reported and to know whether they had a case manager follow up with them within 7 days, and then you wanted a different rate reported for follow-up within 30 days. So that would be an example of reporting stratification, where you're sort of reporting the measure out at 2 different rates or with 2 different sets of conditions on the measure. And then finally, sent in along, when you're doing public reporting for these quality measures, sent in along with the measure are a number of supplemental data elements. So that includes everything from standardized race ethnicity codes, gender data, source of payment data, etc. So there are a bunch of these that sort of come standard for public reporting so that the results on quality measures can be analyzed to ensure equity of care across different socio-demographic groups. And that, in the very broad strokes, is the anatomy of a quality measure. Here we see a set of specific measures with their identification number, and then also the little galaxy of dots over there to the right is shows what types of programs from that large set of national programs that was referenced earlier. It shows which of those programs these measures are used in. So you may imagine that with the, I don't even know how many measures there are out there right now. I think at last count, easily over 1,000 available measures. From all of those measures, how do you sort of hone in and focus on the specific set that is relevant for your population and that's likely to be used in near-term value-based purchasing and quality measurement arrangements? So one way to do that is to look at how frequently a measure is used across all of these different initiatives. And in fact, there are federal work groups that are trying to harmonize measures across these different initiatives because they understand the reporting burden that goes into reporting on all of these different sets of initiatives. And that's why that framework that we talked about before is important, is aligning behind a specific set of goals and priorities. So here we see a number of different types of measures, right? So the one that we've used as an example a few times already is depression remission at 12 months. We also have some other process measures around screening and counseling for alcohol use, etc. And we can provide a longer list of available measures that are relevant for anybody who's interested. I wanted to take one moment to hop out and look at one of these measures. So this one down here, the initiation and engagement of alcohol and other drug dependence treatment. So just to show you details of what one of these measures looks like. This is that specific, is that specific measure where we're looking at initiation and engagement of alcohol and other drug dependence. And part of the measure is really a justification for why this is important, right? So in order for us to say that we're going to measure anything, we need to be able to argue for why it's important for us to measure that. What impact does that issue have on the overall population? Like, what is the disease burden result of this issue not being addressed? So a lot of that comes down in these measures. And then also, is there a defined standard of care? So for any process measure, is there a defined standard of care for the types of procedures that are being used to treat this issue? So once we get through that, we see this is an example of, familiarly, what we just talked about, the initial patient population, denominator, exclusions, numerator, etc. And all of these are defined. And then these things that you see in quotes here are really, like, these are the value sets that we referenced earlier. So office visit is composed of multiple CPT codes, etc. So that, just to show you one really quick example of one specific measure, of which there are many, and how that measure is constructed. I wanted to thank everyone for choosing to spend their lunchtime with us today and taking an hour to get to know a little bit more about the state of the art and the state of current initiatives in behavioral health quality measurement. And for anyone who has questions, feel free to email the address below or call the phone number below. We would be more than happy to talk through this measurement framework or any other questions you have about starting to design a measurement portfolio that works for your organization to address some of these issues. We look forward to talking to you in a few weeks about our next webinar topic, which is really based around how do you ask intelligent questions that can be acted upon using the data that is available to you, and we look forward to seeing you then. Thank you very much for attending.